So our next speaker is Ted Hong, who's going to talk more about local therapy. He is an associate professor of radiation oncology at the University of Massachusetts and really a national leader in developing radiation and pushing the envelope, specifically for cholangiocarcinoma. So thanks for coming here and thanks for speaking.
Good morning. Thank you very much. And it's so nice to see everybody. It's nice to see some patients that I've met over the years here as well, and I'm very grateful that that everyone's been able to come. I hope everyone's enjoying the meeting. It's really been an outstanding meeting. A couple of years ago, I spoke at this conference, and I did a little bit of a deeper dive into some of the controversy of radiation therapy and what the data was in regards to radiation therapy. It's always a little bit of a messy topic. So I'm happy to say that today I'm going to do something a lot more fun, which is talk about where we're going and talk about some of our newer techniques. What this means, and the good news for those of you who aren't radiation oncologists, is that it means lots of cool pictures and less of a deep dive into some of the controversial clinical data that exists out there. These are my disclosures. So as you've been hearing over the course of these last few days, and as I'm sure all of you are well aware of, biliary cancers do represent quite a diverse group of diseases. And this is really very important from a radiation perspective because the use of radiation therapy really varies based on the clinical role that we're being asked to play. And radiation can be used in a number of different settings, and we've talked in the past about the use of radiation in the postoperative setting. This is one of the controversial areas, perhaps subject to a potential randomized trial, but not one that I'm going to talk about today. Increasingly, though, what we're starting to do is use some of our advanced technologies in the definitive setting, which I'll talk about. Another area where radiation has been historically used, though albeit with more invasive older technologies, is in the pre-transplant setting. I think that's a very interesting space. What I'll be focusing on today are some things that you may have heard of, but maybe haven't had the opportunity to see some of the granular details and techniques in terms of what do these terms mean. Things like proton therapy, stereotactic body radiotherapy, or SBRT, and this whole growing field of integrating immunotherapy in the context of radiotherapy. So moving right into it, we're going to start talking about protons. So protons are something that I think get bandied about a lot in the public literature. There's about once a year, there's an article in the New York Times or the Wall Street Journal about the business model of proton therapy. But there's a lot of misunderstanding about what protons are and why we think about using them. So protons are fundamentally a different kind of radiation in terms of what they are from standard high-dose radiation, which is high-energy X-rays. So protons are charged particles, and unlike X-rays, they have mass. And what this means is they have a defined range in tissue that's proportional to the velocity at which the protons are emitted. And what that means is that we can really define where we deposit the radiation dose. And this is in contrast to high-energy photons or X-rays. So if you think about what an X-ray does, if you broke your arm, what would happen is you'd have an X-ray source, there'd be a film in the back, and whatever made it through would make the picture, and that's what X-rays are supposed to do. They're supposed to go all the way through your body. In contrast, radiation from protons, you can really predict where it's going to deposit the dose. The problem is that if you have a certain energy, the protons very predictably deposit the dose in about a 2 or 3 millimeter range, which is not really that useful unless you have a 2 to 3 millimeter thick tumor, which, unfortunately for us, that doesn't happen very often. So we have to make it a little more practical by spreading out the what we call the Bragg peak over a depth by using a compensator that then moves the range of protons so we can treat a tumor with some thickness. Now, if you look at this, this is the sort of stuff that we radiation oncologists totally geek out over and just absolutely love pictures like this, so just bear with me. But what the x-axis is distance from the skin surface. So you can see here in black, this is the entrance dose of an X-ray, it sort of peaks a few centimeters in and then tapers off all the way through the patient. Unlike, in contrast, protons, there is some entry dose, but you can see it really deposits its dose over a defined range and then just falls off and then just stops. And that's really what the advantage is of proton therapy, and this is the reason why there's so much interest in moving proton therapy into liver tumors. So as an example, this is a patient of mine who had a large liver tumor. This is an SBRT plan. I would say it's a really nice SBRT plan. You can see the conformality of the high dose area here in orange kind of makes this nice picture here, and then we're able to really spare other areas with this. But let me show you what a proton plan looks like. So this is a really simple beam arrangement. We just start treating with one beam from the front, one beam from the side. The dose all gets deposited right here, and then nothing here, here, or here sees any radiation. So you can see that there's something just sort of innately attractive about it. It's impossible for me right now to say if there's a benefit to protons or not clinically, but this is the reason why we're putting so much effort into studying protons. Now, in terms of our first foray into unresectable cholangiocarcinoma, our first phase 2 study was really driven by the observation that in the groundbreaking study from the UK group, of which John was a major part of, in looking at GEM-CIS, 25% of these patients had locally advanced disease, though albeit presumably of all locations in the biliary tract. But you can see here that we weren't really seeing long-term survivors with chemotherapy alone. So the question is, for these locally advanced unresectable tumors, could we be more aggressive with radiotherapy? And this is a study that we did with Chris Crane's group at MD Anderson, where we looked at doing sort of a more aggressive ablative regimen. And what you can see here is that if we don't do an ablative regimen, there's sort of the very similar shape of the survival curve that you can see in the ABC2 curves, but with ablative doses of radiation defined as a sort of equivalent dose of 80 gray or more, you start to see a plateau on these curves. Now, this was a retrospective analysis, so there's a lot of patient selection that goes into this, but we did a phase 2 study evaluating this technology with UPenn and MD Anderson. And what we were able to demonstrate using a 15-fraction proton schedule was that if you look here at the local control curve here, this is the intrahepatic cholangiocarcinoma group here, we're able to maintain at 2 years a high degree of local control, though there were some late failures. Interestingly, there seemed to be a dose response where if we're able to keep the dose above 60 gray, we didn't have any local failures. So this is sort of pointed to us that if we can get there with the dose, we could do really well potentially with these tumors. And this blue line here is the overall survival curve of the intrahepatic cholangiocarcinoma patients. What's reassuring is that this is a 2-year time point. About 40% of the patients are alive, and there does seem to be a suggestion that there is a plateau. And I am very happy to say that Lorraine, Andrew, and Lippica and I are seeing long-term survivors now who are now beyond 5 years with intrahepatic cholangiocarcinoma who never had surgery. So I think that that's something that is very exciting. This is an example of a patient of mine, a 57-year-old woman who had a large intrahepatic cholangiocarcinoma. This is a patient that even Dr. Ferroni wasn't going to take to the operating room. There aren't a lot of those, but she's laughing at me. But this patient, you can see here that we had a little bit of a problem that the stomach was right next to this tumor. So all 3 branches of the hepatic vein were involved. So the patient received GEM-CIS. There's no change in the scans. And what we did is we had a tissue spacer placed laparoscopically next to the stomach to give me a little space. And then we had these fiducials placed. And then I treated with protons in 15 treatments. And this is a proton plan. You can see that we're able to keep the radiation dose off the stomach. One thing that I've been doing a lot with Christina now is really being mindful of trying to keep the radiation dose off the other side of the liver, because Christina and I have a growing group of patients now in whom Christina will actually resect patients if they have good responses, protons really afford you the opportunity of keeping that other side of the liver healthy so that when Christina cuts out the cancer, you've got a healthy, unirradiated liver left that can then subsequently grow back. And this is something that we're really interested in sort of broadening, particularly for unresectable perihilar cholangiocarcinomas. So this patient did well, and what's interesting to me is these tumors take forever to shrink. This is over the course of 4 years, the tumor kept shrinking, and you can see here that you just have this scar now. You can see that there's a lot of atrophy of the left lobe of the liver to the point that you don't really see much anymore, but this right lobe of the liver remained really quite healthy. Again, this is all, single arm phase 2. We do have a randomized trial open nationally. This is NRG GI001, where patients who get chemotherapy with GemCis are going to be randomized to high-dose radiotherapy versus observation. Moving on, I'm going to talk a little bit about using SBRT in the pre-transplant setting. It's another sort of interesting niche area that radiation is moving into. As you're well aware of, the Mayo Clinic has done pioneering work in being able to affect long-term survival in well-selected patients with perihilar cholangiocarcinoma. And this is early data, but what I really want to focus on is the fact that the way they gave the radiation is they would treat this broad field, including lymph nodes, to 45 gray and follow it with ILBT, that's intraluminal brachytherapy, and there's a couple ways you can get the catheter in. So what the idea is you have to thread a catheter into the bile duct and then put radiation seeds in there to deliver this dose of radiation. This is commonly done percutaneously, meaning through the outside, but once you do that, it becomes a big infection risk, and the patient, and it can be very uncomfortable for the patient. So we, like everyone, is very encouraged by the overall survival that was seen in this, but we're less enthusiastic about using intraluminal brachytherapy. And again, this is what we're trying to avoid with doing this pre-transplant technique. So a few years ago, Andrew Zhu, Larry Blaskowski, Lipika Goyal, and others came up with a neoadjuvant paradigm for how we were going to treat our perihilar cholangiocarcinoma patients who were going to be getting orthotopic liver transplantation. And what we decided on is a neoadjuvant strategy of GemCis, followed by chemoradiation with capecitabine, and then instead of using an intraluminal boost, we'd do an SBRT boost, and then they would get maintenance gemcitabine until transplant. So what is SBRT? So SBRT is a very specific form of radiation that requires intensive anatomic localization and definition, as well as really rigorous image guidance, so we can have a couple millimeter accuracy on a daily basis. By definition, at least in the United States, it's 5 fractions or fewer. So that's largely an insurance definition of SBRT. But there's a lot of ways that people can do SBRT. So people will think, oh, I want CyberKnife or Protons. But you can really do SBRT with any good, high-quality, advanced radiation technology platform. And the main intent is to safely intensify therapy and improve local control. So as an example, this is a patient of mine who went to transplant, had a perihilar carcinoma with a small intrahepatic component. It was a little bit like a mushroom. And this patient, I did a 45 gray plan using intensity modulated radiation therapy to this area. And then you can see I did a SBRT boost. So you get this nice, like, tight target area right where the tumor is. And we're able to do this without any invasive procedures. At the time of transplantation, this patient had a single gland that was left after this neoadjuvant therapy. Another issue that we're very interested in is, are we safe? One of the things, as our local control improves with the treatment of liver tumors, another important issue is, are we keeping our patients safe? And the problem is that currently we're doing this based on how much of the liver do we irradiate, what dose are we irradiating the liver to, does the patient have bad liver function right now or good liver function? And this whole area is really begging for a more sophisticated biomarker, because for hepatocellular carcinoma, at least, with X-ray-based therapy, the risk of hepatic dysfunction at 3 months can be as high as 29 to 30% based on a large series from Princess Margaret Hospital. So we got very interested in this. Whenever we do a study, we always collect blood in our patients because we're never 100% sure what questions we're going to want to ask and what we're interested in, but we realized we're actually very interested in this liver dysfunction question. And one biomarker that we're very interested in for numerous reasons is something called hepatocyte growth factor, which is a circulating ligand for a tumor receptor called c-Met. But interestingly, HGF can be overexpressed and oversecreted in patients who have cirrhosis, and it's a little unclear, is this because patients are trying to regenerate their livers in the setting of cirrhosis, or is it a function of them not being able to clear the HGF when they have a cirrhotic liver? But nonetheless, there are patients who have elevated hepatocyte growth factor in the blood, and you can see here that if we dichotomize, sorry about that, our patients by whether or not they were above or below the median, what you can see here is the patients who had an increase in their child's P-score as a marker for increased hepatic dysfunction were almost entirely restricted to the group of patients who had a median HGF above the median. I think that this is really interesting, and this is now the integral biomarker in a randomized proton versus photon trial that we're doing for hepatocellular carcinoma. But what I would say to my colleagues in other disciplines in the room who face potential liver dysfunction is, including my surgeons and interventional radiology colleagues, is I think that this might be a great biomarker to study actually in a lot of other liver-directed therapy settings as well, and understanding a better way to try to keep our patients safe. So just a potential idea for us to think about in a multidisciplinary context. In our hands, this has a strong impact on survival because a lot of patients will succumb to liver dysfunction as opposed to disease progression. And the last thing that I'm going to finish on in my last 3.5 minutes here is the idea for radiation for metastatic disease. I think that my medical oncology colleagues can tease me in saying that I like to irradiate so many people that I'm willing now to start taking on metastatic patients, but it's actually that's not the only reason why we're doing this. We are hoping to capitalize on potential systemic effects of that may be beneficial with radiotherapy. Now, there was a great paper that came out in Nature a few years ago out of the UPenn group where they were trying to identify why patients that were quote-unquote immunologically cold, so those are either tumors that weren't responding to immunotherapy at all, or maybe had sort of suboptimal response rates, like single digits, unfortunately, like we see in a lot of GI cancers. And they're looking for ways to potentially augment the response to immunotherapy. And this group really did something very interesting in that they postulated that if you came in with dual immunocheckpoint blockade with blocking CTLA-4 and PD-1, and adding radiation, perhaps that this could augment the immune response. And what this study showed was that by giving a CTLA-4 agent like ipilimumab or tremelimumab, that you can inhibit the Tregs and increase the CD8 to Treg ratio. And what radiation was really doing in that context was intratumorally enhancing the T-cell repertoire that would allow greater opportunity for identification in the immune tumor microenvironment. And then by adding the PD-L1, you can reverse some of that T-cell exhaustion that can so commonly happen and further encourage oligoclonal expansion of the T-cell population that you really cared about to enhance the effectiveness of radiation. And it's really the idea that if you bring all three therapies to bear, one could potentially get your immune system to quote-unquote wake up and get tumors to respond to immunotherapy. But the problem is we know virtually nothing about if radiation actually helps, and if it does, how are we supposed to do this? And this is something that Andrew Lippick and I were always wrestling with, is what's the right sequence and fractionation, and how should we be doing this? And to be honest with you, ultimately, we just had to make something up because there was just no really good data. The data would suggest that priming and concurrent was important. We want to do more than one treatment, and we want to do big doses per treatment, and that's sort of how we came up with this schema, which is a study that will hopefully open in the next month or so at MGH. This is a study looking at dual immunocheckpoint blockade with durvalumab and tremelimumab. And what you can see, what we're going to do is give a single cycle to sort of prime the system, and then we're going to irradiate something 8 gray times 3 concurrent with the second dose of the immunotherapy, and then we're going to continue the immunotherapy as long as patients are doing well. And you can see here that we're going to give the doublet for 2 more months, and then they go on to a maintenance phase of the PD-1 inhibition alone. So we're really excited for the study to open. We have a very similar study that's already open in colorectal and pancreatic cancer, and we're encouraged by what we're seeing with this, which gives us high hopes for biliary tract cancers and HCC. So in conclusion, radiation, admittedly, and again, I really want to avoid getting into this, is controversial in cholangiocarcinoma and biliary tract cancers. But I think that there's a lot of interesting things that we're looking to do, because ultimately what we're trying to do is bring therapies that will help control cholangiocarcinoma in a way that's safe and improve the quality of life of our patients. And I think that integrating into a multidisciplinary setting, as I've been very fortunate to have at MGH, is with my colleagues who are in this room right now, is really the key. And I think that trials are obviously ongoing to address some of these questions, but there's a lot of exciting things coming down the track here. I couldn't do this without a huge team, again, a lot of whom are in this room right now. And certainly thanks to all my patients, particularly those of my patients who are here who made the trek all the way from Boston. Thank you very much.
Thank you, Dr. Hong, for that really exciting talk on radiation, another treatment we can put in our toolkit to help patients live longer and live better.